development. Today, I will touch upon the poor ovarian response, or age, and the thin endometrium. The major action of growth hormone, as you can see, they produce from the pituitary, and in the liver, they can produce IGF. And the IGF then recruit the primary follicle and primordial follicles, and also inhibit apoptosis, so the follicle can grow. The second major function is they can act in the thicker cells, produce abundant androgen, as well as in granular cell to produce estrogen. So the steroidogenesis, as you can see here, the growth hormone in the thicker cell, and this is granular cell, they can enhancement the P450 side chain cleavage. So the cholesterol, they can produce a progesterone, and finally androstenedione and the testosterone. And this androstenedione and the testosterone, they can diffuse to the granular cells. And the second action, the growth hormone, they can enhancement of the aromatase. The first one is to create the side chain of cholesterol, and then the diffusion of the testosterone, they can convert by aromatase to estrogen. And at the same time, the androstenedione also, they can biosynthesize to E2. So you can see this effect of growth hormone to produce estradiol. After ovulation, the growth hormone, they can also act to the luteal cells. So you can see, again, the enhancement of P450 side chain cleavage. So the progesterone production, as well as androgen production in luteal cells. So they have dual functions. And in the follicular genesis, as you can see, they can act, play important role in follicle selection. So in the FSH independent stage, they can act on primary and preantral follicle. After selection, they can enhancement the E2 production, as well as after ovulation in the corpus luteum. So what is the function of those patients with poor ovarian response? We published a paper, how to use low-dose growth hormone adjuvant therapy with ultra-long ovarian stimulation protocol in poor responders. Also, we demonstrated this treatment, they can display non-inferior pregnancy outcome compared with normal responder. And this is our protocol. So this is phase 1 studies. In 2010 to 2011, we collect 180 IVF patients with stage 3 fresh transfer, and the recruitment criteria is much to Bologna criteria for poor responders, including 2 of the 3, as you know: advanced maternal age, previous number of egg retrieval less than 3, lower AMS level. So we have 2 groups, group 1 with GH treatment, group 2 without. And those 2 groups received GnRH ultra-long protocol, GnRH-A starting on preceding cycle day 1 to day 3, and ovulation induction with gonadotropin from day 35 to 40. And the co-treatment with GH starting dose is very low. Remember, it's low dose, only 4 IU, starting from day 2 or day 3 for 3 days. So altogether, only about 12 IU for 3 days only. And that's our result. As you can see, the left-hand side is GH group, and this without. The patient age very similar, AMS level similar. However, after the treatment of GH, you can see the E2 level, oocyte number retrieved, number of embryo transfer, clinical pregnancy rate are improved in GH group. However, the abortion rate is similar, and ongoing pregnancy also much better in GH group. And then we look at those patients age under 40. You can see here, again, you can see the pregnancy rate, implantation rate is much better in growth hormone for treatment group compared with control. And that is significant. So this implantation rate are much better. So how about those patients over age 40? So we examine analysis the old age patient, another two groups. Again, you can see although the egg number increased, however, the pregnancy rate is not much difference. So the impression, the conclusion is maybe GH treatment beneficial for age under 40 group. Then we conduct phase 2 studies next year, 2012 to 2012, the October. Again, we collect each arm, 160 patients. The left-hand side is poor responder, and the right-hand side is normal responder. And the poor responder, we supplement, treat with GH, and this without. As you can see, the age, 39, 35, AMH level, total FSUs, E2 level, all are much less inferior in the poor responder group. You can see here, number of oocyte retrieval, less. Number of good quality embryo, less. Number of embryo transfer, less. However, when you look at the pregnancy rate and the implantation rate, almost identical. See, there's no difference. So there's very interesting data. We can rescue those poor responders when receive GH treatment. They can reach as good pregnancy rate as normal responders. Now that is our first conclusion. And then again, we look at those patients age under 40, poor responders, normal responders. Again, you can see very similar pregnancy rate, right? 39% and 41%, and as well as a very similar implantation rate. However, you see all the parameters are much inferior compared with responders. So again, they can rescue and improve the pregnancy rates for those patients in poor responder age under 40. So how about the age over 40? That's phase 2 start. Again, you see almost no difference. You see the pregnancy rate similar, implantation similar. Although maybe increase the other parameters are not so great as the normal responders. But we also then only focus on those patients to between 40 to 42, 42. As you can see, very similar pregnancy rate, 42% and 30%. Implantation rate are very similar. So the phase 2 studies, our impression is young patient under 40, GH group much better. Even they can improve the pregnancy rate as good as the normal responder up to age 42. So that's our second impression, our conclusion. So we summarize these these studies. In phase 1, as you can see, poor responder versus poor responder much better, almost double the pregnancy rate, significant difference. And then two phase adding together, you can see poor responder versus normal responder, again, very similar, right? So that is the beauty of the growth hormone, because they can rescue or improve the poor responder in terms of the pregnancy rate, and as good as normal responders. And then you can see this for poor responder versus poor responders, you can see almost double pregnancy rate in all age group. And then we review the articles. I see my good friend John Yovich from Australia. he also published a paper in RBM Online, the growth hormone supplementation in poor responders, they can achieve significant more babies delivered per transfer than control group. You can see 20% versus 7%. So that's significant. So again, his findings very similar with us. And then I will discuss the meta-analysis of this treatment in poor ovarian responders. As you can see, for poor responder, they can improve oocyte and embryo outcome. So you can see the number of oocyte retrieved, number of M2 oocyte, and the embryo available for transfer all are improved. You can see mean difference, 1.6, 2.0, and 0.7. So in poor responder, the oocyte embryo outcome is much better in treatment group. And also, Roger Hart also published a very similar result. You can see the growth hormone significantly increased the number of oocyte retrieved. You can see the odds ratio is 2.1, and so in favor of growth hormone treatment. The other study, I think, is the reproductive human reproduction update, also showing the poor responder, the pregnancy outcome, lab birth rate, odds ratio 1.6 better. Clinical pregnancy rate, odds ratio 1.9, also in favor of growth hormone treatment group. So that is another meta-analysis. The third one is when we look at the summary, you can see in growth hormone treatment group, all the parameters all are increased. The odds ratio, you see, birth rate, clinical pregnancy rate, implantation rate also much better, as well as the endometrial thickness. You can see a mean difference also much higher in GH group, and also number of oocyte, M2 oocyte, transfer number, all are significant difference in treatment group. But the most important is this supplementation of growth hormone may improve some reproductive outcome, but not the lab birth rate. So there's one paper published in Fertility Sterility. You can see here, clinical pregnancy rate, yes, you see odds ratio 1.3 cross 1, so in favor of growth hormone. However, when you look at the lab birth rate, although odds ratio 1.3, but it cross 1, so maybe not so significant. And also the Roger Hart also published the same data. Lab birth rate also cross 1, right? So not significant. So GH increased the lab birth rate without significance cannot because cross 1. Then we'd like to discuss how about the endometrial receptivity when patients receive this GH treatment. The growth hormone, they can act the endometrial cells, as you can see here. So the growth hormone, not only to the ovary, also they can act, play important role the endometrium function. As you can see, the endometrial receptivity also improve by enhancement, increase the VEGF production, alpha V beta 3 production, the thickness, and also the blood flow of the endometrium. So all these function, they can improve the higher implantation and the pregnancy rate. Then they will look the literature review to see the effect of growth hormone on endometrial receptivity via molecular biomarkers. So there's 2 studies. The first one is in vivo animal models. The second one is in vitro cell studies. So two different studies. The first one, you see the in vivo animal study, they use different mouse model. So in the end, you see the outcome. All are positive effect. They can increase the IGF-1, leaf is implantation factors, alpha V beta 3, MMP, MMP9, so OPN. So those parameters also increase when animal receive the GH treatment. So that is the positive effect. How about this in vitro cell studies? Again, you can see the positive effect. You see the cell proliferation, leaf receptor, HAXA10, all are increased. So again, animal studies, in vitro studies, all showing the effects of growth hormone in improve endometrial functions. How about the thin endometrium? Again, there's some meta-analysis. You can see the GH for treatment in women with thin endometrium, they can improve endometrial outcome. So you can see the endometrial thickness improve, mean difference, 1.5 millimeter. Multi-layer endometrial rate, also as rate 2.6. Visible blood flow, also as rate 1.8. So all improve the endometrial function. And then again, they can this in thin endometrium also improve the pregnancy outcome. As you can see here, clinical pregnancy rate, implantation rate improve after this. That's no doubt. But most important is here, endometrial thickness. There are three major functions: thickness, multi-layer, endometrial with blood flow, all are improved. You can see mean difference increase 1.5 millimeter, and multi-layer as rate 2.6, and as ratio of blood flow as rate 5. So again, you can see the enhancement of this endometrial function. And this is a case report from my side. This is 41 years old lady with infertility for 5 years due to thin endometrium, 0.1, 0.5 after HRT. So you can see here, very thin, 0.1 centimeter. And then I gave the patient a 12 IU of growth hormone on day 2 and day 4, respectively. So the patient only 2 shots, altogether 24 IU, and the endometrial thickness increased to 0.8 centimeter on day 11. So you can see here, 0.87 on day 11. So she's pregnant after frozen embryo transfer. So this is a very interesting, unique cases for those patients with thin endometrium. So how about the old age over 40? Then we conduct phase 3 studies from 2022 for 2 years. So each arm we recruit 600 patients, 500 and around 500 patients. Left-hand side with GH, right-hand side without. Again, you can see all the improvement in number of oocytes, M2 oocyte, cancellation rate decrease. You can see here only 1.7, and without increased cancellation rate. Number of embryo at critical stage also much better here. And the cycle without a cryo also much less. And this patient average 42. M is very low. And so again, you can see initial impression is every parameter also improve in those patients age over 40 plus poor responders. And then we stratify by age, because age is very important. So then we separate 2 groups. The first group is 40 to 42. The second group older, over 43 and older. Again, and then 2 groups without growth GH and without. As you can see here, all the parameters, number of oocyte, M2 oocyte, embryo at the previous stage, good embryo also improve in GH group in either 42 or over 43. So that's very evident. And then we stratify by AMH value. You can see here. So again, we've divided the AMH level less than 0.5 or above 0.5. So two groups. And right-hand side, you can see all the parameters in patient receive GH in respect to the number of oocytes, and some of the M2 oocytes are much better in GH treatment group. So that is very interesting because I stratify with age and age value. And again, so the initial impression is the growth hormone increased the oocyte quantity, you see, in women age over 40 with low AMH. Or you can see the oocyte quantity all improve. And then we stratify by PGTA. Maybe you ask, do you do this good quality? So we stratify by PGTA. Again, left-hand side, growth hormone, treatment, the other, no. So we look at the cryptic stage embryo without PGTA. Okay, as you can see, implantation, the chemical pregnancy rate, clinical pregnancy rates, all are identical, not a significant difference. And we look at the blastocyst transfer without PGTA, you can see the clinical pregnancy rate 46%, 45, clinical pregnancy rate, mean initial rise, all are very similar. And then for those patients receive PGTA, again, you can see the pregnancy rate is 56, very similar. But most important is the mean initial rise of beta-ICG after 14 of embryo transfer seems to be better in GH group compared with control. You can see 1900 beta-ICG IU rather than 1100. So maybe the growth hormone, some effect of the embryo quality, but it needs more studies. So how about the normal responders? So GH supplementation in those patients with normal responder, the impression is no improvement in IVF pregnancy outcome. So you can see here, without GH, with GH, all the relative risk are no difference. So if the patient is normal responder, please don't use a growth hormone. So in conclusion, I think in our phase 1 studies, the use of the GH in low dose in those patients with poor responders may achieve satisfactory result in E2 level, oocyte number, and the embryo transfer numbers. And especially for those patients, the pregnancy rate and implantation rate all improve if they are under 40 years old. In our phase 2 studies, the pregnancy rate in poor responders with GH co-treatment is comparable with normal responders without GH adjuvant therapy. The GH may enhance endometrial receptibility, increase the thickness of endometrium, and improvement of oocyte quantity. And the GH supplementation in normal responder showing no improvement in the IVF pregnancy outcomes. And the growth hormone co-treatment in fresh ET may increase pregnancy rate, but not decrease abortion rate, very similar. So in fresh transfer, of course, they can increase. And our phase 3 studies, by using the GH improves ART outcome in older patients via improving egg and embryo quantity, decreasing cancellation rate, but maybe not quality of the embryo, but it still needs some other study because you see that 14 HCG is much higher in GH group. And the frozen embryo transfer outcome in women very old, over 40, use embryos with GH supplementation do not increase implantation rate, clinical pregnancy rate, but initial rise of beta HCG is higher in treatment group. But I think the number of mTOR oocyte is matter because the cumulative pregnancy also better. But for single cycles, probably the implantation clinical not difference. But long term, you look at the cumulative pregnancy, probably is better. So it remains to be determined whether it is not the female age rather than the poor ovarian function can categorize the female population who would benefit from growth hormone co-treatment. And this study has been done in the last 14 years. So many research teams from Taiwan, in many medical centers, my laboratory, and my research team from TMU. Thank you very much for your attention, and I'm very happy to entertain some questions from the audience.
Thank you, Chii, for that excellent talk on a very controversial subject, because the evidence in literature is quite controversial. There are few papers which say that probably there is benefit, whereas many which say that there's no benefit. I think there was a paper by Rob Norman also which said that growth hormone does benefit poor responders. And basically, you've looked at all the parameters, and I think you've also divided the patients according to their AMH, and you've shown the benefit. So according to your study, it's only if you do a fresh transfer, growth hormone is beneficial and not in a frozen embryo transfer. Is it?
Yes. The stage 1, stage 2 is fresh transfer. Fresh transfer, day 3, because that's about 12 years ago. So you use a fresh day 3 transfer. But remember, the fresh transfer also some beneficial effect derived from IGF-1 to the endometrium, right? I just mentioned the endometrial receptibility, the thickness also improve. So there are dual effects. They can improve the egg numbers, increase the E2 number, as well as the endometrial function. So that's the beauty of use fresh transfer, age under 40. But for age over 40, only good for 40 to 42. But over 42, maybe the pregnancy is so great. That is the phase 1 and the phase 2 studies.
Yeah, and I think your study has looked into the endometrial receptivity with growth hormone. Yes. I don't think there's any other study, I think, as far as I have read, which have looked into the endometrial receptivity, I think. I don't know. I'm not sure. Are there any other studies which have looked into the endometrial receptivity? Because
in human endometrium, they also have receptors of IGF-1. So growth hormone, how to, they can, as I mentioned, the animal studies, cell studies, and also human studies increase the thickness of 1.5 millimeter. That matters, you see, in average. So if the patient is very resistant, thin endometrium, probably you can use. And my study is only low dose. I know the growth hormone is very expensive. So I use low dose, 1 vial. Before it's 12 units, so divide by 3 days. Start from the day 2, day 3, day 4. Only 3 injections altogether. So you can see the effect. But I don't like I think this study from Australia, I think the Rob Norman, they use start from the luteal phase injection for 3 weeks. Oh, that is very expensive. And he correct about 70 cases only, but the end, no difference. But please don't use in normal responder, please don't use a long start from luteal phase. That is, but result is very, not very promising.
So if I understand right, only for 3 days during ovarian stimulation, along with the gonadotrophins.
Yes, along with gonadotrophin.
Only on day 2, day 3, day 4.
Day 4. For poor responders, normal, poor responder, AMC low.
And how was the dosage? 4 units? What's the
Because
dosage?
nowadays, before there's 12 IU 1 vial.
IU.
So you can 3 days. Now I think it's from Merck. Now it's 20 IU in 1 vial. So you can use 7 IU for 3 days. 1 vial. Yes, 7. And
7,
finish.
7 and 6 again. Yeah.
Especially
But
if
there's always extra in it, na, so it comes to 7 only.
Yeah.
So there's a question.
Sir, I have a question, sir. Sir, how low was the AMH? I mean, the lowest cutoff? Or did you base on AMH? Of course, AFC you would have seen, but AMH, what was your cutoff?
My phase 3 study, we collect 500 each arm. The cut less than 0.5, age over 40. That's phase 3 study. Age over 40, less than AMH less than 3.5 nanogram. Extremely low. Now, but you see the parameter all increase. Even I stratified by AMH, by age, by PGTA. You see still, ear parameter are all improve.
So there's a question as to which route of growth hormone is
Subcutaneous.
endometrium and whether you instill it into the cavity. I don't think it's instilled into the
For
cavity.
thin endometrium, yes.
Yeah.
For thin endometrium, yeah. And for thin endometrium, you can use just 2 or 3 days. For my case presentation, she only received 12 IU for 2 doses, day 2 and day 4. And after day 11, see the thickness from 0.5 to 0.8. Yeah. And finally, 5 years infertility, thin endometrium, now pregnancy after 2 shots of GH.
So it's given
Subcutaneous.
Yeah.
But that's an impressive improvement. Just with 2 doses, day 2 and day 4, and you find by day 10.
Yeah. Because you see, day 2, day 4, so after about 10, and the day 11, almost about 9 days. So already they can have some beneficial effect from day 2 to day 11. So they gradually produce IGF and stimulate or increase the thickness of the endometrium within 9 days, from 0.5 to 0.8.
This is during the ovarian stimulation.
Yeah.
You do the HRT at the same time. She received a frozen embryo transfer, and then in addition, 2 shots of GH, day 2 and day 4, respectively. Low dose.
That's really impressive. I think it might change our practice. We are definitely going to.
We can try.
Yes, we will. Yes.
Day 2 and day 4, 12 units, sir? Or 4?
How many units?
Okay. Now the Merck produced growth hormone is 20 IU, but in fact, you can obtain about 24 IU. A little bit more, not exactly 20 IU. It's 24 IU. So you can give 12 and 12 for two injections. Do you know what I mean? Even before that's 10 IU, but in fact, when you examine the total dose, it's 12 IU, 2 IU more. So now it's 20 IU, but actually it's 24 IU altogether.
But most studies actually were done where the growth hormone was given from day 2 till the day of HCG.
Yes.
But I think, just with 3 days of growth hormone, your results have really improved. I mean, I think we should try that.
Yes, Madhuri, this treatment only focus on proliferative phase, not the luteal phase, right? Because I would like to increase the egg number, only proliferative phase, not luteal phase. So start from luteal phase, I think, to
No, but then, the whole of proliferative phase will be till the day of trigger, no?
Till the HCG.
Till when we are giving the HCG. So you're not using it throughout, no? You're just using it only for 3 days, no?
Only 3 days, yes.
Okay.
So
that is a good thing, no, ma'am, that it will keep the cost. It will be cost effective also. I mean, if you just give 3 days.
Logically, it helps in recruitment. So
yeah, that's why it increases basically the quantity of.
But the recruitment.
I have a question. Now, this
Yes.
protocol that you have mentioned about growth hormone on day 2 and day 4 for thin endometrium, I suppose this is only for people who have an unexplained thin endometrium. Definitely not Asherman's or, a patient with the premature ovarian failure who also has a hypoplastic uterus. In such situations, will it help?
You can try. You can try some Asherman syndrome after the surgery, after hysteroscopy. You can try.
We can.
Yeah.
Okay.
You can try.
And in the subcutaneous route, not intracavity.
No. Because the growth hormone, intramuscular or subcutaneous, you can go to the liver and then produce IGF-1.
Yeah.
The major one is IGF-1, act on the endometrium, up the ovary. Yeah.
Okay.
So not the
So it has
intra
to be
treatment. Yeah. Not like the PRP they use the intra cavity. No.
Yeah, that's an interesting use. We were actually not aware for thin endometrium. I think, yeah, all of us,
And
that's a beautiful point for the rest of us to carry home, that in thin endometrium too, we can, as a last resort. I mean, there are times when we get too frustrated with thin endometrium. Any other questions?
There are no other questions.
I think my first 3 studies collect about 500 each arm and look stratified by AMH by age, PGTA. So you still look at all the parameters, egg number, M2, oocyte number, embryo number also increase. But the quality are still, I just mentioned. The pregnancy looks similar, but you see the HCG rise different. Day 14 after transfer, you see one much better. So
I also wanted to ask, do you do PGTA even if you have small number of M2 sites which are there and small number of embryos? The number of embryos are less. Would you still do PGT or would you transfer them without doing a PGT? Because many a times then we are discarding the embryos, and if they are mosaic, then the chances that if whatever little chance they had of pregnancy would not be there.
Good questions. In my centers, those patients over age 40, okay, when they underwent PGTA, only 20% of the blastocyst is euploidy. That means 1 out of 5 blastocysts undergoing PGTA, only 20%. So if you don't use PGTA, it makes the miscarriage rate or
Pregnancy rate.
the pregnancy is very low.
Oh.
Yeah, that's based on about 2,000. We have 2,000 in the last couple of 2,000 PGTA, the big data.
Yeah, but if you just have less number of embryos and all are abnormal, then what do you do?
Yeah. So if the patient with many blasts, okay, she's old, she'll maybe get an 8, 10 blastocyst, then I do PGTA, because from the 10 blastocyst, I can get 20%. That's too good quality. But for those very poor, and only each time you only get 1 or 2 eggs, and sometimes no blastocyst, maybe we accumulate all the day 3 or day 5 embryo, and then after 3 or 4 trial, transfer all at once. No PGT. So depending on the patient's AMH low, probably just transfer.
What maximum number, sir?
Also better.
They pool the embryos.
Yeah.
What is the maximum number of embryos that you transferred? Over 40.
Say it again.
Have you transferred 4 or 5 embryos also? When you said transfer all the embryos, what's the maximum number?
If day 3 transfer, I prefer day 3 fresh transfer, because the beneficial of endometrium, fresh growth with growth hormone, day 3, without the PGTA. Because day 3, if the patient 40 to 42, you still can get 42% pregnancy rate in my center after GH. Day 3, I show the phase 2 studies. 40 to 42, but after 43, very low. Yeah, so that is some turning point. 42 is the turning point. At least Taiwanese patient, I don't know in your country.
It might be different here.
Much lower, because they age much faster actually. And I think when we just have 2 or 3 oocytes and embryos, I think it's better to do a fresh transfer because, again, when you're freezing and thawing, it's going to result in epigenetic changes.
Yes.
What is your thought on that?
I have been done a multi-center, multi-nation study AMH in the last 5 years, including India. We recruit 5,000 cases from 10 countries. And the most common prevalence of PCOS is India, Malaysia, and Vietnamese, 3 countries, most common. The top indication of infertility or PCO is the top 3 countries.
No, I just wanted to ask you if you have less number of embryos, then would you prefer doing a fresh transfer or a frozen? Because if you're going to do a frozen transfer, it's going to result in it can result in the epigenetic changes because of the freezing and thawing. So I normally prefer doing a fresh cycle. So I'm asking.
Fresh transfer. Age very old, 43, 44, fresh transfer, day 3.
Any other questions?
So you said the benefit of growth hormone, age 40 to 42, is best if you do a day 3 transfer on the endometrium. The benefit is best on the endometrium only if you do a day 3 transfer.
They also benefit of the egg number, increase E2, and also benefit the endometrium.
If you've given growth hormone, day 3 is the best thing, not a day 5.
I will tell you, for the patient age 30 and age 40, the endometrium also different because the mitochondria, everything, young endometrium, old endometrium also different. So the IGF also made some mechanical effect to the endometrium in age older patient, not young patient. So when you only the fresh transfer, you can get this benefit, not frozen. Frozen or HRT, no more effect of IGF-1 to endometrium.
Thank you, sir. Thank you. So we're going to change our practice. I'm definitely going to implement this and see if there's a change in practice in our success rate, which will help us. It was very informative.
For PGTA, for many blastocyst sisters, I think frozen transfer is the choice because when you get 10 blasts, you get to frozen transfer.
Yes.
With or without PGTA, still get a very respectable pregnancy rate.
Any more questions?
So AMH is the key when you use the AMH. AMH age is key when you decide to use the GH with or without. Normal responder, please don't use that. No benefit.
You mentioned 42% pregnancy rate between 40 to 42-year-old women. Is it the live birth rate you're talking about or clinical pregnancy?
That's clinical pregnancy rate, ongoing pregnancy. Yeah, of course, you can some miscarriage rate, maybe 15-20%. Yeah, but very similar.
So the live birth rate is around 30%?
About 80, yeah, that's 80% of the ongoing pregnancy rate. Because
the phase 1 and phase 2
miscarriage. Yeah.
The phase 1 and phase 2, the results were talking about only ongoing pregnancy rate. Phase 1 and phase 2, we were talking about ongoing pregnancy rate, not about live birth.
Ongoing, yes, ongoing.
That's impressive, sir. That means GH must be contributing in some way. Yeah, thank you for that.
So ongoing is already after 24 weeks. Yeah, you count it after 24 weeks pregnancy.
So those were the 2010 to up to 2012. Those studies, the first phase 1 and phase 2, I noticed they up to 2012. So they must have delivered. You wouldn't have the live birth rate.
But some are. This paper was published 5 years ago.
2019.
Some are not easy to follow. Some because come from many places. So finally some deliver in Taipei or not, maybe outside. So some not easy to follow.
Lost to follow. Fine, sir. Ma'am, we'd like to thank.
Should I conclude?
Yes. Yeah, you can.
Ma'am. Yeah, thank you so much, Dr. Chii, Ruey, Tzeng, Thank you so much for joining us. It's been such a wonderful, enlightening talk, I must say, sir. For sharing your experience, we are very thankful. I'm sure all the members are carrying some points for their practice going forward. Thank you, Dr. Madhuri, ma'am. It's such a pleasure, and we thank you so much for getting sir here to talk to us about growth hormone, which has always been an enigma. I thank all the office bearers, Dr. Nivedita, Dr. Lavanya, Dr. Anuradha, everybody who is here for the webinar. I thank all the members. Thank you so much for encouraging. I'm sure you all have enjoyed and have some take-home points. Thank you all. Have a great day. Bye-bye.
Thank you, Chii,
Thank you.
for giving us time.
And apologies for the technical glitch initially.
We would have had a better attendance. Our attendance would have crossed 100. It's just because of the technical glitch, I think so.
No, it's fine. I mean, you can send them the recorded one. So we've
Yes,
recorded it.
we've recorded.
Yes, we have recorded.
So we'll put it.
Yeah.
Thank you so
Thank you.
much. Thank you, everyone.
Thank you. Ma'am,
Thank you,
thank
sir.
you. We have a
Ma'am,
special
thank you.
thank you to Dr. Madhuri for organizing this.
Thank you,
Thank
Madhuri,
you.
Patil.
Yeah. Bye.
Thank you, ma'am. Thank you, sir. Thank you, guys. Bye.